I'm sorry, cuz. We can't dilly-dally today. Oh no, why am I so big? I should have probably looked at that a little bit more. Maybe. I wasn't strong in art anatomy. I think this looks okay. Anyway, we come. Good morning, good afternoon, good evening. Welcome, 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 welcome. Like I said, we can't dilly around today because today I'm not even supposed to be streaming. I have a thing at 7 and right now it is 4:37 in Bearcat Mountain time, and so that means I only have like a limited time to go through 81 pages of notes with you. Wow, so exciting. That sounds horribly daunting, but thankfully a lot of the concepts that we're going to be talking about are like photos and really just quick, like this is how you do it, this is how you do it, this is how you do it. So I think we should be done within the 2 hours that I'm allotting myself. But if we do have some extra time, I do want to see about talking about some of the lower extremities, or aka the leggy content as you see in the title. So we'll talk about like hip, ankle, knee, so I don't know why I skipped that, and foot pathologies. Bearcat extraordinaire. Wow. Hi Yoshi. Hi, welcome. Let me say my hellos and then we'll get into it, okay? Okay. Hi Bubba. Hi, welcome. Let's go. Welcome on in. I appreciate ya. So much potential. So much. Hopefully, again, I'm just a student. I'm not a doctor. I can never diagnose anyone, of course. But, how do you call it? If you do find something wrong, definitely do talk to your primary care physician, okay? Okay, not a doctor, just I'm going by the book of whatever the hecky they teach me, okay? Okay! The table of contents is just to be really fancy, okay? We'll go through everything in order, but we do have a lot on our plate today. Blah. We're gonna be eating so good though. You know, honestly, I ate really good. I ate some sushi today, so I'm like, so good. I would have streamed way earlier, but like TLDR basically, cause I went grocery shopping today as well, and so I was like, oh, I'm getting sushi to treat myself, and I went to a different supermarket, not my normal one locally, and I was just so lost. You ever have that happen to you? I'm like looking around and the employees are staring at me, and I'm like, this is very a parent when I was trying to scan eggs and it wasn't scanning through, and the guy looked at me and I contacted him. And he came over and I'm like, I'm so sorry. I thought I could do self-checkout. I didn't want to bother anyone. So that was my day before any kabask. Anyway, sorry. Hi Jay, hi, welcome. Yay. Hello, welcome. Hi Ashley as well. Hi, welcome. Thank you for that. Ahoy! Hi Atomic, hi, welcome as well. Welcome. Pata, hi. Thank you for the wiggle. Hi Weeb, hi, yeah, hello. I hope your paperwork or whatever the heck you're working on is very, very good. I read Sunny's thing. Hi Sunny! That's so funny you mentioned that. Sunny says, hi Tips. Leggy content? Do you get to see the results from those bike workout sessions from your room? I know you enough as an active individual who uses the bike regularly, not the lazy kind that uses their bike as a clothes hanger. Smiley face, winky, wink. Listen, it's not a clothes hanger right now. It's a jungle scarf holder. It's holding the giant bear plush I have. Listen, but I haven't done anything this past month. This month has been, what do you call it? Difficult. I'm sorry. And so I contemplated, because I was just talking about this maybe a stream or two ago. Maybe so either Monday or Tuesday. And I was just like, oh wow, TikTok's recommending me those like walking pads, but I didn't think the walking pad is beneficial if I don't have like a standing desk, you know what I mean? But it was so small and portable, and it was $150, which is cheap in all things consideration. Then you have to be considering like, why is it cheap? But it was a coupon and blah 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 blah. And I kind of want to do it because it's much easier walking than sitting on the bike. I feel like you're more conscious on the bike when the bike seat's really uncomfortable and you're like, ow, my ischiotuberosity, my butt bone, ah. But I won't give in because A, I don't have $150. B, I already have 2 things to work out with. And C, I'll do better. I think you, I promise you. I'll send you a leggy photo and be like, da-dang, da-dang, da-dang. But even without the leggy workout, my leggy is fine, okay? Okay, that is the strongest thing about me. My arm, noodle. My tummy, don't talk about it. What else is there? Everything's daijou booty. Don't worry. But we've your paperwork. I already said yeah, hello. Sorry, I'm like, oh. Yeah, very subtle though. I promise I'll be back on the grind after next week, because next week is my finals and so I hope you understand where I'm coming from, you know? Caleb, hi, welcome. She's gonna go squat bodyweight pros. Let's go. Brother. I will try my absolute best. Anyway, wait, one moment. I forgot to do some shoutouts on the also. Let me shout out Jay. Let me shout out Caleb. And oh yeah, SG Dustin. Da-dun. But yeah, I guess plushes do need their workouts. Every good household has a jungle scaffold. You had to see him. He's so my room is a reflection of my mental state right now. So I want to apologize. You're gonna look at my room and be like, Tippa, what the? But I have no shame. It will be cleaned when I come back this weekend. I'll put it into images and video. Ignore there's a ribbon there because baby Peas likes to play with the ribbon. There's a gift bag because my mama bearcat gave me a belated birthday gift. There's a neck pillow so when I go on trips and travel. And the jungle scarf is like, in the massage tables. Oh my goodness. Anyway, let me get my cursed hand out. I actually don't know where it is. Oh, I found it. Gosh darn it, why is it blue? One moment. Ta-da! Thank you for the redeem. I just have to resize it. Holy heck. Holy cow. Holy moly. Should I just put it behind me? Oh, it's a little bit too behind me. Oh gosh darn it. I will never find peace in this world. sorry. We're going very deep right now. I'm so sorry. This is not supposed to be a deep conversation. Yeah, he is just hanging out there. I'll delete that photo in a little bit. Anyway, Rika, I think we're good. Yeah. He's a little plush. He could use a little workout, I guess, too. It's Jungle Skull. It's a lot plush, actually, but we won't get into that. Anyway, let's talk about practical stuff. So this weekend, as you know, I'm going through my own little personal heck weekend and heck week, and so I'm gonna let nothing faze me. I'm only gonna be focusing on this and leggy content because those are the two practicals I am most worried about. Next week, I'll worry all about neuromuscular because that is what I'm most worried about after my practicals. So yay! But let us get started, okay? So today, our content that we're gonna be talking about are differential diagnosis, which is basically the different ways that you can potentially be sick and how that may show, because some things are not so straightforward, but sometimes when you exhibit a sign, it's very indicative of something else, and we'll heavily talk about this. And I think a good example that we'll see in a little bit is in the integumentary system, which is just a fancy way of saying your skin system. So let's get to it. Ta-da! So let's talk about systems of reviews. So there's review of systems and systems review, and it's kind of like, God, whoever named this, go heck them, you know? Like, what the actual heck? Why would you do that? Well. Let's learn the difference. So the review of systems is part of the screening process. So when you get to see someone, you recognize to see if there's maybe clusters, and clusters are just associated signs and symptoms of a possible medical referral. So sometimes what happens is that you may want to refer someone out if they're not fitting typical musculoskeletal patterns. So basically they're like, I'm having I forgot which shoulder, gosh darn it, left or right shoulder pain. I want to say right shoulder pain. Oh my goodness, Caleb, you could probably help me with this one. But you know, there's actually something wrong with their liver. So you're trying everything you can in your power to replicate all this pain that this person is complaining about, and then you're not able to. And it's like, might be a little bit more sinister. They might present with constitutional symptoms, and that's something we'll talk a little bit more in detail about, like a list. But constitutional symptoms are basically indicated that you may have some systemic disease, a disease affecting the whole body, and that could be a fever. You can have rapid weight loss, like let's say you lost 7 pounds in a week, brother. That's not healthy, first of all. Second of all, it might be indicative of like, oh, there might be something really, really wrong. Fatigue, night sweats, chills, etc. We'll go down the list in a little bit. And then pain out of proportion, like if you touch someone and like you're like lightly grazing your finger, like I don't know, grazing your finger. And they're like, oh my god, that hurts. Yeah, that's a little bit too dramatic, and the pain is out of proportion, and that might be indicative of pain. Again, there might be something more sinister happening. So that's review systems. You review and you're like, this is a little bit out of the norm. I think I'm going to refer you out. Now, systems review is a system review. So body systems. So we're talking about cardiovascular, your heart, pulmonary, your lungs, integumentary. So we're talking about the skin, musculoskeletal, your muscles, neuromuscular system, which we'll talk about later, the client's ability to communicate and process information. You know, cognitive stuff does definitely play a big role. And if there's any learning barriers, because the whole thing with rehab is not only getting the opportunity to get your patient to be better by various exercises and whatnot, it's the idea of like, hey, do they understand this? Patient education plays a big role in any medical field. So it's like, if they don't understand it, then what's the point, you know? Hi Matt, hi, welcome. Sup, nerd? Ignored. Anyway, so I'm just skipping all this, so don't mind me. So let's talk about red flags, okay? So red flags is a little and you don't want to be a walking red flag. We talked about, well, we never really talked about this, but I'm sure you guys are familiar with lots of red flags in relationships, you know, people who don't respect their boundaries, people who are attention seeking, red flags, stay away from them, stay away. But when we talk about red flags in history, though, what happens is you want to see that these red flags are, well, very urgent. It could be high risk of serious disorders such as like infection, inflammation, cancer, or fracture. And then we have yellow flags. And yellow flags are kind of like, you gotta be really cautious about this. This isn't necessarily saying to stop treatment, but this is something to definitely keep an eye on, you know? So yeah. I can practically hear the song. Same. But what if red is my favorite color? You know what? Red is also my favorite color, but you should never stoop so low to have someone to be a walking red flag, you know? Ta-dang! Love yourselves, okay? If something's wrong with the person that you like, please get standards! Anyway, so for red flags, what's gonna happen is that you're gonna have general malaise. So what's gonna happen is that you're just basically like tired, fatigued, kind of like a laziness, and just feeling unwell. Unexplained fever, so they just have a high temperature, you know? And we're talking about like over 100 degrees Fahrenheit or whatever that is in Celsius. I'm sorry, Cubs, EU Cubs, I'm sorry, I'm American. Unexplained weight loss, so again, more than 10% of the client's body weight in 10 to 21 days. So 100, let's say you're 100 pounds. Oh, maybe more realistic, hold on. Let's 150 is a good middle ground between 100 and 200, right? So let's say you're 150, right? If you suddenly lose more than 10%, which is about 15 pounds in a week, or a little over a week, in 10 days, that's definitely very alarming. That's not normal. The normal body weight you should be having is about, I think, what is like a pound or two, like a week, you know what I mean? So to lose all that in more than a week, get out of here. Cancer and history, definitely a red flag, because there's just some things you can or cannot do. Prolonged use of corticosteroids, so some types of medications. Trauma and history, and we're not talking about the emotional scars of your red flag relationship. We're talking about the trauma in a sense of like, hey, did you hurt yourself in a fall or a motor vehicle accident? Night pain is also indicative. Night pain can be very common in things like if you have carpal tunnel syndrome, night pain is pretty prominent. And I think if you do have cancer, night pain is also very prominent. But I mean, you get night pain for various things, you know? Kisawe! I love you! Have a good one. Thanks for stopping by. Don't worry. Goodbye. Thank you. No pain, no gain, though? Wait, please. You know, honestly, sometimes you do have to take the risk with some people or in some experiences, because if it doesn't kill you, you learn from it, right? And you're just like, wow, I'm never doing that again. Or, you know, actually, that sucked, but now I know better, you know? It is, yeah, you know, it could be nice, I guess, if you really want to look at it in a more positive aspect, but I wouldn't really recommend it. Anyway, Matt says I'm a walking red flag. I'm staying far away from you as possible. And Atomic says it's all good because my favorite color is blue anyway. Let's go! No, red is still my favorite color. I really like maroon. Anyway. Other red flags are also going to be widespread change of sensation in arms, legs, dizziness, problems with balance or vision, because that's definitely something we can't really treat. If you have like a different sensation in your arms and legs, that might be more neuro related, and again, just a red flag. That means if you lose sensation in your feet, you're not able to feel it, maybe you're going to have difficulties with walking. Maybe you're not going to be able to drive because you can't feel how like much pressure you're putting on that gas pedal. There's a lot of things you have to be cautious about when you know, change sensation, you know? I think the rest are pretty like self-explanatory. As for yellow flags, basically the person's beliefs, appraisal, and judgment goes into the care, because some people, oh my gosh. I'm sorry if you're one of these people, by the way. I do want to, I guess, formally apologize. There's some people who don't believe in medicine. And they're like, you know, my body can handle it. And, you know, I've had this guy, one of my coworkers. Because I was telling him, I'm like, yeah, COVID's spreading again. Like in my immediate family, my brother got sick, and another one, like I know like 3 people, including family, who recently got sick within the past 2 weeks of COVID. So I'm like, oh, just be careful, because he's a slightly older individual, and he's like, I don't care if I get it, da 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 da. My body will fight it off, and da da da. And don't get me wrong, your body has an awesome immune system, but obviously sicknesses affect different people, like I still haven't got COVID, so that's also because I am very cautious and I don't like to go out. So homeopathic remedies, I think it's called. I feel like that's something along those lines. Let me double check with you, Ashley. Hold on. I'm going to check it out, but I got distracted. Homeopathic remedies. Made from a variety of sources such as plants, animals, and minerals. They're considered safe and free from serious fever. Yeah, but people who don't even believe in that. People who just don't want to take anything. But people do seek alternatives like homeopathic remedies like that, and they feel like that makes them feel better. And whether it does or doesn't can play some part of placebo or if it's actually effective, but I'm not too well versed to go dive into that, Emotional responses definitely play a role into care. Something we talked a little bit more recently in the most recent neuromuscular chapter of some of the notes I was trying to review yesterday. And basically it's the idea of that if you have like a negative Nancy individual, they probably will not heal as someone who has maybe like a more positive mindset. And just pain behaviors and also another yellow flag to be cautious of, because even though the situation and condition may not be hurting the patient as much as they're letting on, it's still the idea that they are fearful of doing certain things and they're scared of pain, so you just have to kind of oblige by that, oblige, I don't know. Anyway, so there's more stuff of red flags, so we can talk about that a little bit more. So personal or family history of cancer, a recent or last 6 weeks of infection, a recurrent flus or colds that people just can't seem to shake off, like I keep getting this flu. Recent history of trauma such as, again, the MVAs, the motor vehicle accidents and falls, and which can lead to a fracture of any age, or even a minor trauma in adults with osteopenia or osteoporosis. And osteoporosis is that like weakening or softening a bone. A history of immunosuppressants, so we have like our steroids or organs. Oh, sorry, my mouse. And history of injection and drug use, the infections. Other risk factors are not necessarily red flags, but something you do need to keep in note, because the older that we age, the weaker our immune system, the more prone that we are to getting certain things. So we can do, so we have to be careful of people's risk factors for substance abuse or use, such as alcohol or alcohol or other drugs, tobacco use, age, gender, BMI, exposure to radiation, alcohol use, sedentary lifestyle, race and ethnicity, because remember, some people are more prone to other things, like multiple sclerosis is apparently very prominent in older white females. Domestic violence, a hysterectomy. I know, I've never seen that other word in my life. And occupation can definitely play a role in that. My immune system is being a great paper, so big props to medicine. Let's go! I thankfully have a pretty good immune system. Not saying that I don't get sick. I tend to get sick, I think, really bad once a year, maybe at most. But obviously with not contacting as many people, and I'm sure people taking better precaution, I feel like I haven't been seriously sick, and I've only been sick with what was it, like laryngitis, where I lost my voice for a little bit. Yeah, that was fun. Hi Steph, hi, welcome. Big ol' hand. Yep, you can thank we for that one. Da-dung. Alright, so sometimes all the time, not really. Okay, so walking red flags. So people come in and this is what they may present with, and these are humongous red flags, so please keep this in mind. You have no idea what's wrong with you. There's no known cause, there's no known etiology, it just kind of randomly happened one day. Or maybe it has like an insidious onset, again, randomly just occurred one day, we don't know what it is. You feel like your symptoms are not improved or relieved by physical therapy interventions. So if you're like, hey, I'm here for my shoulder and we're doing everything we can, and you're like, yeah, no, it still hurts, may need to consider, like, maybe this is more than it has to be. If physical therapy intervention does not change a clinical picture, it may even get worse. So if it doesn't improve and or it gets worse, then it's definitely like, symptoms get better after physical therapy but then get worse again are a red flag. A significant weight loss or gain without effort. A gradual, progressive, or cylindrical presentation of symptoms where it could be worse, it could be better, or it could be better, worse. Like, oh yeah, I was feeling good and now it's bad again. You're kind of like on this weird roller coaster. Another red flag is that if it's unrelieved by rest or change of position, like no position's comfortable. And a lot of people who are like, standing is so uncomfortable, you take a seat and you're like, oh wow, you get that sense of relief. Well, people who may have some kind of disorder don't. And even if you lay them down or prop up their legs and put them in the world's most comfiest position, they're like, yeah, I still don't have relief from this, which sucks. But if for whatever reason, if it's relieved by rest, their symptoms, it could be rest, positional change, or application of heat and time, those relieving factors will no longer reduce the symptoms. There's only so much a person can lay down in this scenario and be like, actually, this is not working for me anymore. Symptoms seem out of proportion. Symptoms persist beyond the expected time of the condition. You're unable to alter the symptoms, whether you try to provoke it or alleviate it or eliminate it or aggravate it. Yeah, you can't alter it. The pain is just always there. It doesn't fit an expected mechanical or neuromuscular skeletal pattern. There's no discernible pattern of symptoms. There's a growing mass, and it's a tumor until proven otherwise. Maybe you have a postmenopausal vaginal bleeding, and maybe you have bilateral symptoms. And the bilateral symptoms is maybe you have edema, so swelling, and maybe like your legs or your arms or your hands or your feet. Numbness and tingling, skin pigmentation changes, clubbing, which we'll talk about a little bit with the integumentary system, and nail bed changes, skin rash, and changes in muscle tone or range of motion for people with neurological conditions such as cerebral palsy, spinal cord injury, traumatic brain injury, multiple sclerosis. All those are going to be red flags, so please, again, be on the watch out, okay? Oh my goodness, there's more. Let's read it because red flags are important, even though this is like a very squished image, so I apologize. But before we get into that, let me hydrate. I feel nasally and I feel hydrated or dehydrated, so one moment. So pain patterns for red flags is that maybe they have back or shoulder pain, which is a very common location for referred pain. Other areas may be affected as well, but the two areas signal a particular need to take a second look. Pain is accompanied by full and painless range of motion, so there's no restriction. They're able to do their motion, but there's still pain. Normally pain limits you, but pain that's not consistent with emotional or psychological overlay. Night pain, symptoms are constant and intense. Pain is made worse by activity and relieved by rest, and that could be stuff like intermittent claudication, or it's the idea of like, yeah, when I walk and everything like that, my legs hurt, but when I sit down, I'm better. Okay. Sorry. Pain described as throbbing, vascular, knife-like, boring, or deep aching. Pain that's poorly localized, so the person's complaining about pain, but they're not able to pinpoint where it is. They're kind of like, oh, it's just my arm. And it's like, where? Oh, like all of it, like all around. And it's like, oh. Pain coming and going like spasms, and pain accompanied by signs and symptoms specific visceral systems such as the GI, GU, GYN, cardiac, pulmonary, endocrine. Changes in musculoskeletal symptoms with food intake or medical use is also going to be another pain pattern and or red flag. This could happen immediately or happen several hours later. Associated signs? I think we're good. So what happens is that when you do an interview with an individual asking about stuff, you probably don't want to go down that list. Hearing that history, you'll be able to identify red flags. But things like, hey, have you been experiencing abnormal sensations such as numbness, pain, and pins and needles, headaches, night pains, morning stiffness, lightheadedness, trauma, night sweats, constipation, easy bruising, changes in vision, changes in menstrual patterns, gait or balance distribution, change with rest, shortness of breath, muscle weakness, failure of conservative intervention, so they're not able to change their symptoms or feel or report a improvement within 30 days. If they're experiencing sweating, weight gain, do they feel a heartbeat in their abdomen when they lie down? Now that's actually something super serious called triple A, abdominal aorta or aortic aneurysm. And what happens is that you basically get a little lump, sac, protrusion of your aorta. And if you're familiar with aorta, even the slightest, you would know that is a major artery that comes off your heart. Like, I'm sure you guys are vaguely aware about the how the anatomical heart looks. You know that thick artery that comes up from the top? Yeah, that thick artery is called the aorta, and it goes all the way down to you your abdominal area, and hence the triple A, abdominal aortic aneurysm. But yeah, one of the key features is that you have middle back pain, I think. Excuse me. And you feel this heartbeat when you lie down. Have you experienced cramps in your legs when you walk for several blocks? Have you experienced abdominal pain? Have you experienced the changes in the integrity of your nails? And have you experienced prolonged use of corticosteroids? So again, your medications. At the defect of the aortic endothelium, if I recall correctly, I want to say yeah. definitely along the lines of yeah. Please go get that checked. You should not play around with your heart health at all. So, what are our constitutional symptoms? Again, recall that symptoms indicate a systemic or general effect of a disease that may affect the general well-being. I can't read today, Cubs. Being or status of an individual. So again, if your patient's coming in and they have a fever, they're having unexplained perspiration or sweating, they sweat and it could occur anytime during the night or day. Nausea, vomiting, diarrhea, pallor, which is like a paleness of the skin, dizziness or syncope, which is like a fainting. These people just drop. Fatigue and weight loss are going to be your constitutional symptoms. And if your patient is experiencing really just one of these, you should already have concern. But definitely two or more is just like, okay, buddy, oh pal. We have to probably assess this a little bit more in detail, like why are you feeling like this. But before we get into super detail, we could talk about vital signs and talking about how patients and people should normally be presenting. So let's talk about pulse. I feel like we talk about heart rate a lot. So recall that the normal heart rate is anywhere from 60 to 100. You guys know I have a very low heart rate. I'm at like that 60 cusp until I play like Elden Ring, you know what I mean? But that's always very fun and exciting. It'll raise my heart rate. But anywhere between that, it's okay. Anything higher, if your normal resting heart rate, like you're just sitting here, is over 100, you're considered someone with tachycardia. And then if you have less than 60, you have bradycardia. And those all have their own wacky, I suppose, features and all that jazz. So please go see your primary care physician for more details. Let's talk about blood pressure. I feel like a lot of you guys may hear it because it's like, oh, my diet really influences my blood pressure, or maybe the stress I'm in, or maybe it's something hereditary where like my mama bearcat has high blood pressure. I've never been there. Thank goodness. I don't think I've ever like inherited that. I've always been normal every time I go check at the supermarket, but I don't feel like I, what do you call it, have to worry too much, you know? So let's see. So normal, your systolic, or that top number, should be 90 to 119, and your diastolic should be 60 to 79. Anything within this range right here in the green is normal. Pre-hypertensive meaning right before hypertension, high blood pressure, you might be a little bit over the normal. So you might be anywhere from 120 to 139, with your diastolic being 80 to 89. Stage 1 is going to be 140 to 159, and your diastolic is going to be 90 to 99. Stage 2 is very scary. I knew someone who had stage 2, and we're just like, yep, to the ER with you, have fun. Stage 2 hypertension is when your systolic blood pressure is over 160 and your diastolic is over 100. That is insane numbers about how hard your heart must be working to pump all this blood, and it's just like, why is it doing that? Why? So definitely go see your doctor. And of course, when you have hypertension, maybe stage 1 or pre-hypertension, there's definitely some medication that you can be prescribed to manage that a little bit better. With all that talk of blood pressure though, let's talk about orthostatic hypotension. So I'm sure most of us have experienced this at one time, and I feel like a lot of people kind of draw it onto the idea of maybe they're anemic. But sometimes when you get up too fast, there could be a sudden drop in blood pressure, so you might feel a little bit lightheaded or dizzy. And normally this is when someone's laying from supine, or they're laying on their back, laying on their spine, supine, up to an upright position. So maybe someone's laying down and they sit up and they're like, oh, whoa, my head. You have the opportunity to check their blood pressure, and if you do see that sudden drop, then it's like, oh my goodness. Alright, let's move on. What about our core body temperature? So for core body temperature, there's different ways that you can check. You can use the mouth or oral or the ear. And really, your body temperature should be anywhere from 96.8 to 99.5 degrees Fahrenheit. Again, Cubs, I'm sorry. I don't know the conversion. I refuse right now. I thought that was normal. That is not normal, Weeb. Weeb, okay, stay right here, Weeb. I got you. Hold on. But yeah, that's your normal body temperature. Your mouth is pretty much the same. But your ear can be just a little bit warmer at 97.2 to 100 degrees Fahrenheit. But again, normal body temperature anywhere between 96.8 to 99.5. If it's a little bit lower, there could be various reasons, honestly. One thing that we'll briefly talk about, I believe, is hypothyroidism, which is a condition where you have less thyroid in you. Marks. And what happens is that you end up with a lower body temperature, in contrast to hyperthyroidism, where you actually end up being much warmer, but there's no actual indication of you having a fever. You just have a higher body temperature. So ta-dang. But Atomic, please have a good one. Thank you for stopping by and enjoy your gym workout. Oh my goodness, don't be the jungle scoff. Ta-dang. No. I know what you mean, Weeb. That's why I said stay right here. I got ya. I think right after this we're gonna go to skin, so I got ya. Respiratory rate. So the amount that you inhale and exhale should be anywhere between 12 to 20 times in a minute. There can be different changes, but again, just all depends on your body and maybe some condition that you have. Your pulse oximetry. So there's this little clip that goes onto your fingers, and it'll read how much oxygen that you have. And what happens is that it should be anywhere between 95 to 100. If you have anything less, you might have someone who's been using tobacco, or someone with some kind of COPD, chronic obstruction pulmonary disorder. Womp womp womp. Skin temperature, normally used with people with diabetes. So what's going to happen is that the increased temperature might be early signs of inflammation, but if for whatever reason you have 4 degrees Fahrenheit difference or more between each extremity, the left or right foot, it could be a predictive risk factor for foot ulcers. Don't ask me about that. I just wrote that from the textbook, but huh. Playback, hi, welcome! I can inhale and exhale so fast. Me too. I love hyperventilating. Hi, welcome. Other vital signs, by the way, is pain and your walking speed, but we won't really get into that. But these are the other details that we should, quote unquote, at least obtain some kind of baseline, you know? Alright, we talked about the Aspero questions. Alright, let's get to the integumentary system. And the I can't say this word. The integumentary system is our skin. Patients may have or complain of recent rashes, nodules, or other skin changes, unusual hair loss or breakage, or even hair growth, change in the nail beds, and itching. And some questions that are really important to ask is that, hey, have you experienced any change in skin color? Have you experienced any differences or changes in your wound healing time? Like sometimes maybe you got a paper cut. Should have been probably closed relatively soon, but it's been like a week and it's still open. Kinda concerning. Have you experienced those changes in the integrity of your nails? Now, this is where we'll show pictures and whatnot, so don't you fret. We'll definitely get that going. And have you recently experienced a skin rash? You know, it's like, okay, how's the rash? How did it look? And, you know, from there we could determine, like, okay, what's really happening. So, for the examination of skin, we could do different things. So we could check for the color of the skin. Maybe they're normally tan, but they look very pale, and it's kind of like, okay, what's happening? Texture, turgor, moisture, lesions, hair distribution, and warmth. And we'll talk about this all in detail. Let's actually first go with color, pigmentation of the skin. So the following can indicate a systemic or again an entire body disease. So let's talk about pallor. Again, if I came to you and you saw me like white as a ghost, that's kind of like, wow, Tippo, that's not your normal skin color. What the heck is wrong? Could be various things, to be honest. But one of the things that we can do to detect iron deficiency anemia is if you... How do I say this politely? If you peel your eyelid down, your lower eyelid down, and you look down into it, it should be red. But if it looks pale, you might be present with iron deficiency anemia, which is related to decreased oxygen delivery through the entire body. And this again, it plays that whole rule of like, oh, I got up too fast. So definitely something to check out. Jaundice. Jaundice is pretty apparent. Jaundice is just like a yellowing of the skin. And so we can see it in this patient here that they have jaundice with their yellow eyes, and even yellow tinted skin. If you do look up jaundice, there's a really good example of this guy who's just yellow. Like he looks like a Simpsons character. That's how bad it is. But again, this is indicative of a liver disease. Your skin could also be yellow because maybe it's nutrition induced. So maybe like you eat a lot of carrots and you ate carrots and that's all you eat, carrots. For whatever reason, your body will change a little bit yellow because of that. Or you might have some kind of weird blood disease. Womp womp. But those are indications of why a patient might present with yellowing of the skin. For red, we're not just talking about sunburn. This person has not gone out. They've been a shut-in for, let's say, 5 years. And they go to their primary care physician, but their skin is just red. Why? Well, this could be indicative of some kind of exacerbation of other skin disorders that they may have, or just flat out, it just might be an inflammation of the skin. Skin's angry, skin's mad, skin can't find peace, skin red. And then you also have depigmentation such as, oh my goodness, vitiligo? Oh my god, I don't think that's how you pronounce it at all, but I will just go with that. Or burn injury. So this is an example of that first word I just said, where people have patches of different pigmentation throughout their skin, you know? Hi Lucas, hi, welcome to the couple chat, welcome. How's it going? Oh, it's going well, welcome on in. We're just learning about the human body. Am I a walking red flag? Okay, listen. No, I'm just kidding. No, you're not. Hi, welcome. Let me give you a oh my goodness. Let me give you a hacking shout out. One moment. Da-dum. Alright. Welcome. We're just talking about skin. Woo! Oh, do you have anemia? Have you pulled down on your eyelids and stared at it to see if it was red? And if it wasn't red, what color was it? Ooh. Nice. Uh-oh, skin. Uh-oh. Are you gonna stop by before you go live? Absolutely no hecking worries. Please have a good one. Enjoy the stream. Thank you for stopping by. I don't have real skin. I'm artificial. Oh, don't have anything to worry about. Hi, Earl. Hi. Welcome as well. Welcome. Big uh-oh, stinky skin. So, other than color, by the way, for skin, we also need to check the texture. If it's soft, is it tight, is it rough? And it can be indicative of different things. Scrolls. Go! Oh, you got Neko! Let's go! Thank you! I feel like I'm losing my voice. Oh my goodness, laryngitis part 2 again. Hey, thank you so very much for going to Sugar Bear community. Thank you for gifting sub to Neko. Thank you for going to Sugar Bear community. I'm sure Neko appreciated it very much. Thank you! And I will inhale air. Twitch is lying again? What else is new? It's okay. Well, enjoy. Have a good one. Thank you for stopping by. Ta-dang. Oh goodness. So Turgor. So Tugor? Anyway, what happens is if you pinch your skin, and I'm not talking about harshly, like pinch the skin on top of your thumb, if you were to squeeze it, it would go back correctly? Correct? Question mark? Sorry, I can't speak anymore. I apologize. If you squeeze the skin on top of your thumb and you let go, the skin should return back to where it was. But with people who may have decreased turgor, what's going to happen is that skin slowly goes back, and that might just be an indication of dehydration. Moisture could definitely play a part, whether your skin is dry and oily. Lesions we'll talk about in a little bit in a moment. Hair distribution, I think we talked about this a while back, but basically if you don't have a good distribution of hair, that might be indicated that you might not have good blood flow. So like sometimes if you look at your legs and you're like, wow, I have this random patch gone, like what's up with that? Maybe you don't have enough blood flow in that area, because blood flow is going to provide those nutritions, and that's going to help with the hair growth. So ta-dang. Warmth, basically understand that generalized warmth can be indicative of a fever, localized warmth could be inflammation, and coolness again could be various things of hypothyroidism, frostbite, hypothermia, shock, low cardio output, etc. For the skin, if you notice there is some edema or that swelling, if we press into it and it leaves like an indent, and there's like several grades of how to like grade this kind of pitting edema, this person might be indicative of someone who is having a cardiac failure. So their heart is failing them, and there's various stages for that. They can still function, but gosh darn it, do they need medical attention. So what's gonna happen is that this can be confirmed that they're having, or that they have a heart failure if they have pitting edema, because the heart is failing to bring back the fluid and recirculating and blah 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 blah. And again, there's an indentation mark when you're pushing onto their skin. Alright, the ABCDs of the skin. Yay! Let me hydrate. Oh gosh darn it. I wasn't ready to talk today. Like I was mentally ready, but physically I'm not ready. Oh my goodness gracious, great balls of fire. Okay. Let's learn our ABCs together. A, for asymmetry. So we have the difference between normal and abnormal, or even like cancerous lesions on the skin. So what you're gonna look for abnormal is asymmetry, because when it's normal and you have something like rounded and you can break that bad boy into like 4 equal parts, you're like, oh yeah, normal symmetry. But asymmetric is something like this. The borders are going to be even in the normal, while in the uneven, in the more cancerous areas, the borders are uneven. It tends to be one color for it to be normal, but again, if it's more cancerous, it might be multiple colors. Normal should be less than 1/4 inch, which what is that again? I want to say, and I don't want to say it was by my instructor, but I swear I heard someone said maybe that's like the tip of like your eraser on like your pencil. Like it should be around that size, and if it's anything bigger, then again it might potentially be cancerous. And we have to consider our evolution. So this ordinary mole, yeah, this is fine. It's okay to have moles on your body. My mama bearcat has a mole, and I'm like, oh wow, she's like those like beauty Hollywood stars, you know. But the issue is just once it starts evolving and changing size, shape, and color, yeah, that's when you know you might have to get that checked, because it might be something again more sinister. Okay. Hi Mom, hi, welcome! Bearcat, welcome. You made it just in time to learn about the nails, baby. Alright, cubs, time to look at your nails. You don't even need like a manicure or a pedicure, but what happens is that your nail bed, what do you call it? Oh, someone's on my document. What the heck? It's super important. Candace says, really, the development is the most important bitty, and they can absolutely be hacked as long as it's the same. Yeah, sorry, when I talk about this, they don't have to be cancerous, but definitely some areas of concern to be like, You had a couple of moles removed? No! I'm sorry! My professor had the same situation, and one of them ended up being a little bit more serious, and that was like spooky for her. She had it like above her. Oh my gosh, I wish I could show you guys the picture. I did not put this in here. She had this gigantic like gash above her lip, and she got it sewn back, but she didn't tell anyone that was her photos. So she asked like the class's opinions, like, hey, when you see this patient, what do you think when you see this? And one of my classmates is like, yeah, that looks hideous. And she looked at them and she's like, yeah, that's me. Because you can only see a picture of like her mouth with the mole over it. It's just like, yeah, that looks hideous. And everyone's like, oh my gosh. And she's like, yeah, I got this like removed and fixed a few years back. Because if you look at her, it looks like there's nothing there. You know what I mean? So I'm just like, oh. Obviously, no points off to my classmate, of course, but gosh darn it. Anyway, yes, we do have nails. So relatable, bestie. Let's talk about nail bed inspection. So, our nail bed is, well, our nail bed. We know our nails grow, the cuticles, and we cut those every so often, or I hope we do. But what happens is that the bed can tell like a different kind of pictures. So you can have some kind of yellowing, which is like a nicotine stain. So basically the idea of like, hey, you smoke a lot, and if you smoke, please stop doing that. Smile. You can have splinter hemorrhages, and so this is going to be dealing something with your heart health. We have leukonychia, and that can be due to alcohol use and abuse, nutrition, or maybe an MI, which myo and cardiac infarction. Yeah. You can have a spooning, so you see like this discoloration, and that could be indicative of anemia, something wrong with your thyroid, or even syphilis. Your nail beds can look like this, and you can have these things called butte lines, which is also with alcohol, nutrition, and MI. So this random spotting and this have the same outcome. You can have nail pitting, so you see like these little indentations into this, and that could be due to psoriasis. You can have a nail thickening, so sometimes you can see someone's foot and be like, yeah man, that's nasty. The circulation can make it very thick and yellow like this, and if you have something like this, like you maybe like slammed on your finger a little bit too hard, but you definitely didn't and it just randomly appeared, that's definitely more indicative of malignance. Alright, and so that's really that with skin stuff. Let's talk about the cardiovascular. Let's talk about the heart. Wow, amazing. So people who come in with cardiovascular or heart issues might complain or have chest pain or a sense of heaviness and discomfort. I forgot what's the medication people use, but when I used to work in the pharmacy, just even for like a brief moment, nitroglycerin I think was the medication. and they had to keep it on them at all times. And my pharmacist, would always say, please take this medication if you feel like there's an elephant stomping on your chest, because that medication will automatically quickly relieve it, but it's like an emergency, like you need that on you at all times. So yeah, teehee. Palpations, limb pain during activity, which can be again due to that claudication, that whole like again the circulation just not working too well. Cramps or limping. There could be discolored or painful feet or swelling of the hands and feet, and we'll talk about that probably a little bit more later with the pulmonary system. Pulsating or throbbing pain anywhere, but especially in the back or abdomen, and again that goes back to our AAA, abdominal or aortic aneurysm. Peripheral edema, so they have edema or swelling or fluid buildup on their extremities, or maybe they're peeing a lot, but at night. Sudden weight gain, persistent cough, fatigue, dyspnea, Sorry, let me politely look it up. One moment. Dyspnea. Oh yeah, difficulty or labored breathing. Orthopnea, which I think you have to be upright to breathe or something like that. Sorry, all the penias are messing me up. Yeah, orthopnea is a medical term to describe shortness of breath that occurs while lying flat and is relieved by sitting or standing. High or low blood pressure, unusual pulses, we'll talk about this a little bit later, differences in blood pressure from side to side with change in position, and positive finding during auscultation, which we'll talk about in a little bit. So cardiovascular questions you may want to ask to see and assess for red flags is that you want to ask, hey, have you been experiencing chest pain with exertion? Have you experienced lightheadedness? Have you experienced loss of consciousness? And have you experienced sweating without exercise or activity? And this can be referred to as cold sweats. So, do I have all this? Oh, goodness gracious, I have it all screenshot. Okay. Sorry, this is gonna be the boring part. Teehee. So there's different ways to assess the cardiovascular system. So we can definitely do an inspection where basically we can gown and protect for modesty of exposed areas, and we can know for any discoloration or shape in the nails. So the nail shape and colors, we'll talk about the clubbing in a little bit. Evidence of inflammation, edema, so again that's swelling. Maybe they're dealing with cyanosis, which is like your skin is turning blue. And nicotine stains or fingertips. Basically it goes more integumentary. Let's see what else. No, I think that's really it. Just stare and be like, is there anything wrong with you? Oh wow, that looks a little bit swollen. Why is that? Anyway, for palpation, we definitely want to assess for skin temperature to check to see if maybe there's some kind of inflammation. We want to check for arterial pulses, and we want to check the rate and make sure that their heart rate and everything like that and their sensation of pulse is good. Oh, this one's fun. Capillary refills. So capillary refill is to help gauge the arterial perfusion. Very fancy terms just to say press nail bed or the tip of the finger for about 3 seconds, and what's going to happen is that the underlying skin will widen, and then after the release, the normal pink color or the regular color of your nails should return back in 2 to 3 seconds. Hold on. Sorry, baby piece is looking very cute. A delay indicates lack of perfusion, so pretty much what happens is that if it's taking more than 3 seconds, definitely some kind of weird issue, and can indicate like a vasospasm or hypovolemia. Basically it's abnormal. When we talk about pulse, again, we can grade it, so we can track maybe like the radial pulse or the pulse by their thumb, and we can grade it as absent, which it's not there, 1 plus, which is weak, +2 it's normal, +3 it's slightly increased, or +4 where it's like bounding. It feels like it's like coming out of that area, which is spooky. there's different ways to assess the arteries and trying to get pulse. We can get pulse from the temporal arteries. So basically, you know, when you get a headache and you rub on the temples of your head or the side of your head, kind of like diagonal from your, I guess, eye, the side of your forehead. Are these all good indications? Yeah, that's where your temporal artery is. You can palpate and feel like a slight pulse for that. It just goes over different ways to feel arteries. And more edema. Yeah. Okay. Auscultation. So a fancy word, but basically this is where you need to get the stethoscope. You know, when the doctor puts the thing in their ears and then you try to feel, or not feel, but I mean they do, but they try to find your heartbeat and they have that cold metal thing pressed onto your chest. Yeah, that's what I'll be doing. So pretty much what happens is that if the patient is showing some risk factors, especially for arteriosclerosis or even a stroke, we should also take for brutus. So what's going to happen is that the sound that you may hear, called a brute, may be a sign of an arterial narrowing and again a risk for stroke. So basically what you're going to do is place it over each carotid artery, instruct the patient to hold their breath temporarily, and listen for a whooshing or rushing sound, aka that brute. And if a brute is hurt, take note about the pitch, the intensity, the location, and timing in the cardiac cycle. Blah 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 blah. Compare both sides. Blah 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 blah. Another way we could test is circulation and whatnot is to do an Allen's test. So what you're gonna have the patient do, you're gonna tell the patient to please make a fist and compress both the ulnar and radial arteries. So you see this person is pressing down, and as they're pressing down, they're stopping the blood flow to the hand. Then what's going to happen is then you need to instruct the patient to open and close their hands a few times to pump blood out of their hand. And what's going to happen is that with one side, preferably the pinky or the ulnar side first, you're going to release that pressure. And once you release that pressure, what's going to happen is the hand should turn pink in a few seconds. And then what you're going to do is repeat the same process for the arterial side. And it's basically, it's like a capillary refill at that point with the nail beds, but when your whole entire hand. Ta-dang! Alright. They talk about ABI, but we won't do that. Will we talk about Hoffman's? Sorry, this is not the fun stuff I wanted to talk about. But it's good to talk about it nonetheless, you know? So to check for bicycle test of Van Gelderen, smile emoji. The purpose of that is to differentiate between lower extremity claudication pain or neurogenic or vascular. It's to differentiate between the lower extremity claudication as either neurogenic or vascular. And I feel like, hold on, Cubs, I'm so sorry. I've been saying claudication as this, but let me just get the baby Google definition. Claudication again is going to refer to the muscle pain due to the lack of oxygen triggered by activity and released by rest. So again, patients who may do like a quick walk around the community may complain about pain, ache, discomfort, or fatigue in every muscles those times are used. And normally they feel pain in their calves, their thighs, their buttocks, their hips, or their feet. And again, it's just all due to that lack of oxygen that's being triggered by that activity. But again, they feel better with rest. But the bicycle test takes it a step further, and it's like, okay, is this truly vascular or is it neurogenic? Is there like is our brain, is our nerves involved with this? So with that, the patient is instructed to sit upright at a stationary bike and pedal until they're like, I'm having those symptoms of claudication, I feel pain, I don't like this, you know? Have the patient continue to pedal and lean forward, and then remove extension forces in the lumbar spine. Have the patient continue to pedal and lean forward. And what happens is that when you lean forward, you're flexing your trunk and no longer extending it. So thus removing the extension forces in the lumbar spine that may have favored neurogenic symptoms from stenosis. So basically what's happening here is that when you flex, you're opening the spinal canals. And so there's not as much compression on a nerve that it may have been pushing on. So more to that, basically. If the pain persists in the flex position, the claudication is presumed to have been of a vascular cause. But if it's abolished in lumbar flexion, it's most likely going to be a symptom from a neurogenic source. And this is just really important because it gives us a better way of how to address this, how to treat this, and how to potentially refer it out. Holman's test? I don't remember. Oh, I do remember. Let me see. Let me grab a picture really quick. I'm actually supposed to do it. Supposed to do it this week. But I don't think this is the normal way people do it. Alright, so the Holman's test is to screen deep vein thrombosis. So you know how I'm always like, oh my goodness, Cubs, do you need to fight the blood clots and everything like that when we stand up? Yeah. What happens is that you might get a blood clot, and this is the deep vein thrombosis, and what's scary about it is that can travel up to your heart and kill you, basically. So a really important way to test it to see if maybe a patient has DVT is that the patient's going to be supine and that the examiner is going to lift the affected leg and rapidly dorsiflex. So what's happening dorsiflex is bring your toes up to your nose. So rapidly doing that, and the maneuver is repeated with the patient's knee flexed while the examiner simultaneously palpates the calf. Holman's sign is positive if pain is occurring with dorsiflexion on the foot with the knee extended and flexed, indicating the DVT. So basically, congratulations, you may have this thing. Maybe you should go see a doctor. Let me double check something. So the really cool thing about this test is that it actually sucks. It's still used even though it's insensitive, non-specific, and is present in fewer than 30% of the documented cases of DVT. So someone can be present with DVT, you do the test, and they don't end up with a positive sign. Again, this test is not your like end all, be all, or tell all kind of test, unfortunately. So big womp womp. But there's definitely risk factors and clinical findings of how you may be more at risk for a DVT. So previous history definitely would play a part. Active cancer, some type of immobilization recently of the lower extremities. Maybe you've been bedridden for more than 3 days, or maybe you had a major surgery within 4 weeks. Local tenderness along the deep venous system. You have some swelling, more swelling, but more specifically, you have more than 3 centimeters of swelling in comparison to the other extremity. Excuse me. You have pitting edema, which is, let me see. Yeah, you have pitting edema, which is going to be greater in the systematic lower extremity. So even though you can have bilateral edema, there's obviously going to be more swelling in one leg more than the other. Collateral superficial veins, which are non-varicose veins, so basically you're just seeing your veins a little bit more. I think people also refer to that as spider veins. And hold on, babies. I got a little knickknack and I hung it onto my little cork board, and she's like pawing at it, and I don't. Peace. Thank you, baby. Alright. I just don't want, like, I don't care if she plays with it. It's just the idea that if she claws into it too hard, I feel like the board would drop. You know what I mean? Baby, why do you have to be bored? Hold on. Alright. But even with all those clinical findings, by the way, there could be an alternative diagnosis which basically puts you back into the negative too. So I didn't get the opportunity to explain this, and I apologize. But what is this? What is this? Yes, the Wells clinical decision rule is basically supposed to indicate your risk factor of a DVT, and you're supposed to score yourself. So that's why you see a bunch of ones right here. But oh my goodness, I said I would never get sick, and now I'm just sneezing. Oh my goodness, someone's talking bad about me. Boo-hoo, boo-hoo. Anyway, let's say, oh, the person does have a previous history of DVT and they have their entire lower extremity swelling, but actually, you know, they just recently like fractured their bone, so of course that might be normal stuff happening. Then it's kind of like, oh, maybe they're not at risk at DVT because 2 minus 2 is 0. So da-da, da-da. Bless you, thank you, I appreciate it. Sorry, goodness gracious. Another thing we can do also to check the cardiovascular system is to test for the arterial and venous filling time, and this is all having to do with the rhubarb dependency test. So let me pull up a picture because I feel like this is better shown than me just talking about it. So one moment. Alright, Cubs, don't be spooked, okay? Baby peas. So this is someone's foot. Kind of spooky. But let's talk about it. Why the heck is that foot red? Like, why are they like in the dust of super high, spicy hot, flaming hot Doritos, Cheetos, or whatever other spicy chip powder? And what's gonna happen with this kind of test is that if there's pain or a diminished pulse, baby bees. Nah, bro, I'm gonna have to do some. Bye. Sorry, sorry. Yeah, it looks painful. It's not painful. I promise. It's just their blood flow. You know? Maybe not. Here, I'm gonna try to explain it, but now I'm trying to distract baby peas for not, like, what do you call it, trying to tear my corkboard down. Holy heck, baby peas. So let's just explain the test. So the patient's laying supine, and then they elevate their legs to about 45 to 60 degrees until maximal pallor is developed. So basically they're super pale, all the blood is rushing out of their foot. Ta-da! So easy, and it's being rushed out because of the use of gravity. This is why when you see people who have like heart conditions or even swelling, it's important to raise the legs or the feet above the heart so the swelling can go down and then it can recirculate. And what happens is that for clients with compromised arterial blood supply is that this gravity is really going to hack them up. This color will disappear quickly, and so that's why they end up with this paleness. And what's going to happen is that from there, once you see that pallor, you're just like, okay, patient, from laying down with your feet elevated, now we want you to sit up immediately. And so they're sitting up and they're dangling their legs down. And what's going to happen is that with a normal time, your feet should return to its normal color in about 10 seconds. For the ankle and feet, it's apparently about 15. Color change in the lower foot takes 25 to 30 seconds or more, and it's very bright red, hence the rhubarb dependent rhubarb, suggesting arterial sufficiency. Red foot, basically. So it's to indicate that there's something wrong with the arterial system, and you're putting them in, I think, what they call a dependent position, hence the rhubarb dependency test. And again, it's just the blood rushing back down in, which is not normal by any means, as you can tell. You know, they don't have a good circulation. Is basically the TLDR of this test. If you need to get gravity involved to do all this, then you're hacked. Alright, we're slowly but surely getting to the things I'm a little bit more passionate about, so let's try to, I'm gonna try to speed it up on my behalf. Okay, the pulmonary system. So the pulmonary system, now we're talking still, you know, I guess heart, but we're really focusing more on lungs. So what's gonna happen is that your patient may have or complain of cough, hoarseness. They may have some kind of oh my gosh, what is the word? A productive like spit. They might have phlegm, shortness of breath, night sweats, lung pain, pleural pain. They might have blueness or clubbing in their fingertips, and basically you're gonna find positive findings during auscultation. So using the stethoscope and being like, yeah, that's not normal. some questions you want to ask is that, have they recently experienced the production of blood when coughing? Or maybe they experienced the production of abnormally colored substances among coughing. So maybe they coughed up something red or green, and it's like, or yellow, and it's like, what is that? Have you experienced changes in your typical coughing pattern? And have you experienced wheezing? So let's talk about it. So how can we hear the lungs? Well, your lungs, pretty big. This is someone's back. You see the lungs all the way over here? Ta-da! And so what you want to do is you want to check in each lobe. You want to check the left and right, upper and lower lobe. And what's going to happen is like when you're checking in this area, you're going to be checking for sounds. And so you're going to be trying to hear for crackles or wheezing. Maybe there's a stridor, which they describe it as an inspiratory musical sound. I will definitely have to Google sounds of the lungs. You might hear a rubbing, which can also include a creaking or grating sound produced by the rubbing of two inflamed pleural surfaces. So that's super like, oh my goodness. And let's see. So there's different tests of how you want to do this when you're listening to someone's lungs. There's 3 different tests. There's the egophony. There's the we'll get there when we get there. So egophony is what happens is that you have the patient say E, and that's all they're doing. They're just saying E, and then you're palpating on the back with the stethoscope going to different quadrants. And what's going to happen is that if there is something wrong, the E will eventually sound like an A, and it's supposed to indicate that there's like some like fluid buildup or something of the sort in your lungs, which is kind of spooky. Bronchophony is the sound the spoken voice makes over a large airways of the bronchi. Words are louder and clearer in this region in comparison to the peripheral. So an increased sound transmission of 9-9 or 1-2-3. Oh goodness gracious. If I recall this correctly, this is a test where basically you keep having the patient say 1, 2, 3 each time you palpate, and it makes sense that you hear more of it down the midline than going out to the side basically. And then the last one is basically the same thing, but it's in a whispered form. So instead of being like 1, 2, 3, 1, 2, 3, it's 1, 2, 3, 1, 2, 3. Percussion of the lungs. Now this is it's a little interesting. So this one we're just going down in about 5, 6, 7, I guess, 7 spots on each side, and you're supposed to be hearing and feeling for different noises. So when you palpate or do a percussion of the lungs, there's different kind of sounds that you can expect. Normally you should hear more of a resonant sound, which is the normal low-pitch hollow noise heard over normal lung tissue. If you hear something flat, maybe you're hitting bone. Thud, this is more likely something you're going to hear with the heart or liver. And thudness will replace the sounds of what do you call it, resonance, which is something you hear mostly in the lung, if there's soft tissue or fluid that's replacing that, you know? Hyperresonant sounds are sounds that are louder and lower pitched, normally heard when percussing the chest of children and very thin adults. And tympanic sounds are like hollow, high drum-like sounds, and they're normally heard over the stomach, but it's not a normal chest sound. You may likely hear this kind of sound if there's excessive air in the lungs or in the chest, and this normally apparently occurs with pneumothorax. Alright. The lymphatic system is a little bit weird. This is something that the instructor was really emphasizing, but the book doesn't really talk about it too much. The lymphatic system is just understanding that your lymph nodes are going way out of whack and the patient may experience swelling, but that's really all I got from the book. I know a little bit of outside knowledge, but I want to stick with whatever's in the book. Some questions you can ask someone if you are suspecting a lymphatic issues, that maybe they're experiencing excessive thirst, excessive hunger, or easy bruising. And how we're going to palpate all of this is different palpations that you can have in both the upper and lower extremity. But the panic sounds, you know, it's very funny because normally when we have those like really weird group games, and I say weird because it's like grad school and I know they're trying to make it fun, but I'm just like, oh, I haven't seen this in a while, like Cahoots or something like that, and you have to insert a name. I'll always put like tympanic or something like that, or tympanic membrane. It's an ear anatomy joke. Teehee. Hi Ram, hi, welcome. But yeah, let's talk about lymph nodes, okay? So lymph nodes, let's talk about upper extremity palpation, because the lower one, there's nothing like horribly wrong with this photo, but it's also just like, yeah, I'm just not gonna have that conversation right now, okay? So for the upper quadrants, there's multiple things you want to palpate, and you can follow along with me if you'd like, but you try to palpate your nodes, and what's gonna happen here is that you would use both hands and do bilaterally. So you would check for the back of the head or the occipital, so right here, right here, occipital, and then you would move post auricle, which is right here. Post meaning behind, auricle referring to the ear. So from the back of the head, palpate. Hopefully you're not feeling any masses. We'll talk about that a little bit later. We'll do behind the ears. From there, we're going to go to the superior posterior cervical. So we're going to go down here. From here, we're going to move to the superior anterior. So we'll move up here. And then from here, we're going to move into the deep anterior cervical. So same side, but we're just going to go a little bit deeper. So let's go in order again. Occipital, posterior auricle, deep cervical, superficial cervical, and then get in there, deep cervical. From deep cervical, you're going to go pre-auricle, so in front of the ear this time. Then you're going to move over to the parotid and tonsillar area, so just making your way down to like the angle of your chin. So tonsillar at the angle of the chin, parotid just right below the ear. From there, from tonsillar, we're going to move to submandibular, which is kind of the midline between your jaw and that jaw angle. And you're feeling for that. And then submental is going to be right below your chin. And there you go. Those are all the palpations that we're going to have for our lymph nodes. Tip: casually doxing yourself at bearcat school? Brother. And my Discord server, it says that in the school Discord server, you can literally see that I'm streaming right now. So if any of my classmates are sitting here, I'm sorry. Anyway. Ram says, I forced my lymph nodes to work overtime when I was young. Now a lot of sickness barely affects me and been granted the ability to turn off my smell at will. I just hold my breath, but oh my goodness. The human body is amazing. Here's another picture again, so let's do our order. We have occipital, post-auricle, posterior cervical, anterior cervical. Then we get our in-between anterior cervical, deep anterior cervical. Oh, I forgot subclavicle. How can I forget? Heck. Anyway, preauricle, parotid, tonsillar, submandibular, submental, and then, excuse me. The last spot you do want to palpate is above the clavicle, supraclavicular nodes. And these are definitely very palpable when there's a disease. So if you palpated something, it's kind of like, Tippa, what does that mean? And I do have to... Where the heck is the chart? Okay, here it is. So normal lymph nodes, if you palpated nothing, I'm happy for ya. The consistency of the areas that you should have been feeling were soft, not tender, so you weren't like, oh my goodness, that hurts. And it was very immobile. If you were to have an acute infection, maybe it would be enlarged, so maybe you would feel something. And the consistency feels a little bit more matted together. Tenderness, it would probably be most likely tender asymmetrically, so maybe the left side hurts but the right side doesn't, and that it's very immobile as well. But for something more sinister, again, like the metastatic cancer, your lymph nodes are going to be enlarged. You're going to feel those. And the consistency of these are more rubbery or firm. Like think of like those little bouncy balls you might have played with as a kid. Think of it like that. And what's going to happen is that there may or may not be any tenderness, but the mobility, when you move that like lump or that like rubber ball in that area, it's not going to be mobile and it's going to be fixed to underlying tissue. And that's where you need to be like, okay, that's scary. We need to take you to potentially to medical care as soon as we can. So you can also do, the lower extremities, which I think they really specify as like you find the inguinal ligament and you just palpate a little bit there and you do more vertical, like more in the inner thigh of a patient, which is probably very awkward and uncomfortable, to be completely honest with you. And you can also do the armpit. So what's gonna happen, or like upper arm to armpit. So one of the areas we could touch is the epitrochlear lymph node. So we just go right here, just palpate right there. We could palpate within the armpit. So we touch behind, we touch the side, and we touch more medial into it. And you just basically get all your bases covered. And if you feel anything abnormal, then get help. Alright, this is where I get a little bit more passionate about it, but let me politely BRB. I'm going to chug my water, close my door, and maybe get some Mentos because I'm just like, holy heck. One moment. Also, I've also been speaking like for an hour and a half straight, so one moment. Wrong scene. I'm so used to using the other one. Cubs, you're coming in with a lot of questions. I'm afraid I can't answer them. Anyway, hi JB, hi, welcome. Hi Kirby as well, hi, welcome. I think we're all talking about different red flags here. But anyway, let's get back into it. I'm a little bit energized. We have a little less than an hour. Let us politely get into it. We're already like at the halfway point too, so that's actually really reassuring. But thank you for welcome back. Let's hecking go and do this. So let's talk about a little bit something I'm a little more passionate about: the gastrointestinal and the oh my goodness, musculoskeletal are probably like my two favorite systems that I hope I get for the practical, and if I don't, I'll go ahead, excuse me, and cry. So for gastrointestinal, patients may have or complain of abdominal pain, indigestion, heartburn, difficulty swallowing, nausea and vomiting, loss of appetite, changes in stool, bowel habits, so they may have diarrhea or constipation, or may have, excuse me, man, that sushi's going, as fecal incontinence. They may have rectal bleeding, so when they poop they bleed, and blood is present in their stool and or vomit. A skin rash may also be followed by joint pain, and that might be indicative of Crohn's disease, which is actually a pretty common disorder that I know a few unfortunate individuals to have. So some questions you can ask to see if we can indicate and go along with the gastrointestinal issues and indicate red flags. Is there a change in your stool color? Is there blood? Has there been changes of the frequency? Have you been going more or less? Is there a change in appetite? And have you experienced excessive heartburn or indigestion, basically? So how are we going to do some quick screens for the abdominal? So we can do inspections. So we could just stare at it and indicate, hey, what is the color looking like? How does the skin look like? How does the belly button look like? Is it everted or inverted? Are there any signs of visible masses or hernias, or maybe some dilated veins? Because have you oh my goodness, have you seen hepatic cirrhosis? Now this is crazy. Let me see if I can get a belly photo. I hope I'm thinking about the right thing. Oh yeah, but they're not showing me the veins. Okay, you know what? Look at it at your own time. Oh, this one's not as bad. It's pretty bad. So this is a guy, and he has like, again, do you see the veins more prominent, and it's just big belly. The guy is relatively like fine, you know what I mean? His arms are like thin and proportionate. It's just the liver, there's just like, you get like a belly basically with the hepatic cirrhosis because of this kind of inflammation. Anyway, so yeah, definitely something that's observable because that's pretty abnormal. Here's his belly button. He's an alien. Wow, wow, wow. But yeah, it can just get that bad, you know? And so we could look at different kind of herniation. So we could see here the umbilical herniation, which might be common in infants. Incisional hernia, maybe it's an operational scar. We could have the epigastric, so right here, hernia, or we can have some other kind of nonsense over here. Not the point. Point is, that's just inspection. If we look at it and see it's not normal, then we can make notes of it and kind of go from there. What's really important or more hands-on is the auscultation. So you know how we were saying we're doing that for the cardiovascular by getting the stethoscope? Well, you could do the same thing in the abdominals, but what's going to happen is that you're going to divide the belly. Oh goodness, where the heckie is it? Yeah, you could divide the belly into 4 quadrants. So you have an upper quadrant and a lower quadrant, and then it's divided by both left and right. And so what you're going to do is put a stethoscope in 2 different areas, and you're going to be able to hear. And what happens is you should be hearing like a kind of like a gurgling sound, and you should hear about 5 to 34 of those for 60 seconds. quadrants, and that is within normal. Like if you hear that much in each quadrant, should be good basically, and should have probably a much healthier gut. Anything less is going to indicate maybe some kind of constipation, while anything more is going to indicate maybe this person has like diarrhea or something like that, you know? Alright, so in addition to hearing for gurgles and whatnot, another thing we can do is to hear for the aorta and hearing the pulses that we have. So we can hear for the aorta, which again we talked about the aortic aneurysm. We could look for the renal arteries or kidney arteries and hear for that. We can hear for the iliac artery, and we can hear for the femoral artery, which is in a more sensitive area, so you just have to be a little bit more cautious with that, okay? Percussion! So same thing with the lungs, and how we're like, oh, it should be resonant sounding the whole way. The abdominal percussion is a little bit different. So you're gonna have the same different sounds, but what happens is that for the most part, your tummy and your abdominal area should sound like a timpani, and which we said was like high-pitched muscle notes with air-filled viscera and organs. The only time you should hear like a different sound is if you're hitting on bone, so like a flat bone, maybe you hit the rib for some reason, or if you're hitting over the liver, and it should hear a dullness sound. So basically what you're going to do is that you're just going to tap. And you're going to be tapping in all these wacky different areas. And do I have it here? Oh no, it's palpation. So, no, I'll get to that part in palpation, I guess. So that's really percussion. So it's really interesting because to slap the belly, basically, you need to have 2 fingers resting on that area. And you have to use your middle and index finger, and you cross your middle finger over your index finger. And so you have like this weird, like, I don't know, like, oh yeah, I promise to do this, and that's gonna be your like what you do to tap. So it should sound something like this. Maybe I should mute the music. Something like this. Hold on, my technique is so bad. And that's basically the sound you should hear in someone's abdominal. Maybe. Anyway, let's see. Dice. So let's talk about abdominal palpation. So pretty much you could rub someone's tummy, but you know, more educated. And you could rub their tummy so you could palpate for things like abnormal things, like maybe there's a mass, or you want to palpate superficial organs, you want to see maybe there's some muscular resistance, or maybe there's some tenderness. If a patient's complaining of a certain area, let's say my right upper quadrant really hurts, palpate everything else before palpating the painful quadrant. And so when you talk about light palpation, we're going very deep in with 4 fingers, and we're just doing a light 1 centimeter in-depth thing, and we're just rubbing in circles, and we're going to rub at 2 different areas in circles. And again, we're feeling for those 4 things. If you do feel like some kind of guarding, like someone's probably really not comfortable with you touching their tummy, you can ask them to inhale and exhale. Very simple. And what you're gonna do is ask them to relax, because maybe again it's just voluntary guarding. Ask them to take a deep breath, and you know, in through the nose, out through the mouth sort of thing. And it should decrease with that technique. And if it doesn't, and they're not guarding, they're like, what do you mean? They may have something called involuntary guarding, which is something more pathological. And this actually might be that this lining that we have in our organs, the peritoneal layer, might be inflamed, and that's what's providing that guarding. And that's something we definitely are not able to treat and would have to refer out to a doctor. Now let's talk about deep palpation. So we got past all that, got to the layers like the onion. So for deep palpation, we're going to be palpating for masses, and we're going to go super deep. So we're going to be using a bimanual hand technique, so one hand over the other, and we're going to do the same circles. And with that circles, we're going to go a little bit more deep, and we're going to go about 3 to 4 centimeters deep in all quadrants. And if we find a mass, we need to be able to identify it. While you're palpating these quadrants, it's very important to note like different structures we have. So if I was palpating, when I am palpating on the left side, I'll be like, okay, that is your stomach. Palpating this region maybe is your stomach. The right upper quadrant will be your liver. The left quadrant maybe the sigmoid colon, so if there's any pain with that, and the right lower quadrant can be the cecum, which is going to be a part of your intestines. Both of those things, the sigmoid colon and cecum, are a part of your intestines. So basically just palpating and identifying some other structures in there, because if there's pain in that area, then it's like, oh well, I know this is here too, so that might also be the prime cause of why that person might be having pain. Tummy rubs, but professionally? Yeah, basically. If you need a professional tummy rub, I got you. Let me figure it out. Hold on one moment. Oh, yeah. So this is crazy. Okay, so you can actually palpate your aorta. Now this goes super deep. So we did our light and deep palpations. Now let's touch our heckie aorta, that big artery that comes out from our heart, but somewhere along the lines it's in our abdomen. So let's go ahead and palpate it. So how we're gonna do that is use 2 index fingers side by side, and we're gonna firmly press deep into the epigastric area, slightly to the midline, so above the belly button, and you know, our belly button hopefully is in the middle of our tummy. Everyone's not made the same, so just putting it out there. Vague approximations in the middle of your belly. Go above it and then go slightly to the left. What's going to happen there is that you're going to push down until you feel pulses. And what's going to happen is that with your 2 fingers, the index fingers side by side, we're going to lose my voice. We're going to widen the gap between our 2 fingers until we feel the pulse on the sides of our fingers. And what's going to happen is that the normal width should be about 2.5 to 3 centimeters, and if it's anything larger, we need to refer it to a medical examination. Palpating the aorta sounds terrifying. It is, but it's okay. It won't kill you. I haven't killed my classmate yet, so it's okay. So remember that time where I was like, yeah, let's talk about pulses? Same thing here, but in color, basically. We did talk about 2 being normal, 0 being absent, and 4 being like, yeah, that bad boy is going. Even if you try to press on it, it is too strong to obliterate. This is talking about peritoneal inflammation and different things that may happen. They may have increased girth, they may have pain, electrolyte imbalance, rigidity, so it's a little bit rough, it's immobile, like, there's like a bunch of things with it, but someone made a really cute mnemonic out of it, so yay. Here's another picture about all the organs in our abdominal region, and different things we should just note to be like, okay, this is here, and this is there, and this is here, and this is there. Don't worry about it. More of the same thing, but in a different image. Let's talk about Murphy's percussion. So there's some really interesting special tests that we can do together, okay, Cubs? So Murphy's percussion, what we can do is, this is a silly test. You'll go behind the patient, and you know how people are like, oh yeah, grab at the waist. No. What you want to grab is underneath the ribs, and that's gonna be the costovertebral angle. And once you feel under the ribs, that's like the approximate area where your kidneys are. So you're gonna place your hand flat onto their back, right underneath their ribs, and then with the other hand, with the pinky side, you're going to have like a fist, and you're gonna like tap them in the back. So you won't be able to hear that, I'm sorry, but you tap them in the back and you basically ask if that replicates any symptoms, and this is supposed to indicate any like kidney pathology. It's a really strange test. I don't know why I don't have a photo for it, so I apologize, but basically you just hit someone's back, but professionally. Psoas sign is very interesting. So psoas it's a muscle we have on our hips that helps with hip flexion. We have both a major and a minor, and it sometimes just kind of combines to become the iliacus or iliopsoas, which is the iliacus, which is a muscle on your hip bone. And yeah, they both do hip flexion, but there's a disorder. There's a test called psoas sign, and what's going to happen is that on the right side, you're going to ask them to flex their hip. And what's going to happen is that you apply a little bit of resistance, and if they have pain, they may have hypogastric pain. And hypogastric, again, is going to be here. Oh my goodness, I couldn't find it. So they may have pain with like urinary bladder, a sigmoid colon, and or female reproductive organs. But thank you for the hydrate, JP. Give me one moment. Huh? Instructions unclear? Suplex the patient? You might as well. Why not? Let's talk about the obturator sign, okay? So the obturator sign is to test for like any like fluid filled like pustules that you may have. And so for obturator sign, same thing with the right leg. And what's gonna happen is that you're gonna place the patient's leg into about 90 degrees of right hip knee flexion and external rotation and internal rotation passively. So you go with the leg. And with that is that if you place them in these positions with the knee flex and turning their leg in and out, if they experience some pain, again, this pain might be a right hypogastric pain. So again, that's going to be your sigmoid colon, female productive organs, and what was the other one? Oh, and urinary bladder. So, dun dun. Murphy's sign is very interesting in a sense that Murphy's sign is to test for the gallbladder. So what's going to happen is that you are going to go on the right side of the patient's body and you're going to do some weird position with your hands. Excuse me. And pretty much what happens is that once you're there in the certain area, like slightly above the belly button on the right side of the stomach, it'll test positive if there's a sharp increase in tenderness when the patient is taking a deep breath. So test positive, patient has sharp increase in tenderness with sudden stop and inspiratory effect. So basically, you're pushing down and you ask them to take a deep breath and they're like, oh, it hurts. And that's going to be highly suggestive of acute inflamed gallbladder, basically. Ta-da! I don't want to say the medical name because I'm too shy to butcher it up. And McBurney's point, also a very interesting test. So basically, your hip bone, like if you were to put your hands on your hip, your index finger may lay above this hip bone. No, and I'm not talking about the iliac crest. I'm talking about like a hip bone more towards the front, maybe here. You feel like a bony prominence in the front of the hips. What's going to happen is that that's your ASIS, the anterior superior iliac spine. From there to your umbilicus or your belly button, you basically go 1/3 from that, from the ASIS. And this is going to be a very common area of where we associate with your appendix. And what we're going to do is just palpate there. And if there's tenderness, you may have appendicitis. So, yay. Appendicitis may present with a low-grade fever, so maybe your temperature again is over 100 degrees Fahrenheit. You may have constipation or diarrhea, and you may have nausea and vomiting. So, yay! Rebound tenderness. So, similar to McBurry's point, where we kind of just push into someone and hope for the best. This can be done in any area to determine peritonitis, which is again that inflammation of the peritoneal layer in our tummy. And yeah, you just press into these different areas, and the rebound is kind of just like you push in and quickly let go, push in, quickly let go, push in, quickly let go, and if that's aggravating them, that they may be positive for again peritonitis. Inhalation of air. Thank you. I did not look up heel jar sign, but I'm pretty sure you just hit the person's heel. That's the test. You hit the person's heel, and if their tummy hurts, peritonitis. Abdominal reflex, I have no idea. I wrote hold on. And fluid wave, I also wrote hold on. I don't know what I was holding on for, but I definitely need to get these answers, but probably later. So some red flags. Yay, red flags are a favorite. Yay. So what's gonna happen is that if you're having a gastrointestinal issue, there's really multiple ways you can handle it. So with red flags though, especially, we can either try to get direct medical attention, like we stop our session and we get like 911 emergency immediate ER care, or maybe the findings could be a little bit less urgent. Like, yeah, I would definitely talk to your doctor in the next 24 to 48 hours. But even redder flags, yeah, basically, like these things are like, get out of here! Ah! But for emergency 911 or immediate ER, you're gonna have a visible or palpable pulsatile mass in the epigastric area. So like above the belly button, you're feeling a mass, 911. Positive rebound sign is also positive for peritoneal or peritonitis, so 911. And signs of peritoneal inflammation, 911. Anything inflammation with the tummy, 911. But our less urgent findings, something again we're going to communicate within 24 to 48 hours to our doctor, is the abdominal aorta if the width is more than 3 centimeters wide. If we suspect the mass anywhere else that isn't the epigastric area, the absence of bowel sounds can be very concerning, because it's kind of like, brother, why are you not digesting? Signs of ascites, suspected hernia, like maybe you see something, you're like, that's a little weird. Signs of jaundice, again, that yellowing of the skin, because it can indicate something wrong with the liver. And or the patient reports blood in their stool or their vomit. That's definitely something where it's like, okay, go see your doctor. It's not normal to vomit blood. Here are some different things of if we have pain in certain areas, of what it can indicate and why the human body is really neat like that. But yeah, it's not. Julian can confirm, not okay to cough up blood. Please go seek help. Go seek help. Hi Julian. Hi. Alright, I think this is gonna be the last thing, and really I think this is like the second to last thing I have to talk about, so we're making good time. So let's talk about the musculoskeletal / neurological stuff. So patients may complain of joint pain, redness, warmth, swelling, stiffness, frequent or severe headaches, change in vision, vertigo, they may have pins and needles, they may have a change in muscle tone, weakness, they may have atrophy, so their muscles are wasting away, an abnormal deep tendon reflex, which we'll talk about a little bit more later, problems with falls or balance, involuntary movements such as tremors, and seizures or loss of consciousness are definitely things we want to consider for both the musculoskeletal and neurological, but for whatever reason the book kind of combined the two together. Some questions you can ask to identify your red flags is that if there's any abnormal sensations such as the pins and needles, change in vision, frequent dizziness, seizures, or changes in hearing. So with that, we bring it back to our good friend dermatome and myotomes. Yay! So let's talk about myotomes. So myotomes is basically our spinal nerve root providing like the sensation of certain actions. So we'll talk about the upper and then the lower quadrants. So I'm going to try to do this from memory without looking. So if I look like I'm looking, just ignore me. I can close my eyes for this. So what's going to happen with upper extremity myotomes is that your C3 is going to be lateral neck flexion, and what's going to happen is that you can have the patient perform the action, or you can do it resisted. The manual says resisted. I guess you could do it resisted if you feel a little bit more concerned for it, to make sure if it's like weak or strong or whatever, but you could just have them do the action. So you have C3 is lateral flexion, C4 is shrugging, C5 is arm abduction, so their arms are out like T-posing slightly. They might not have their arms straightened all the way. That was C5, right? Yeah. C6 is going to be two actions, which is elbow flexion and wrist extension. C7 is elbow extension, wrist flexion, so it's the opposite. Do we have a C8? Yeah, C8 I think is thumb extension. And then T1 is going to be finger abduction and adduction. Did I do it? Yay! Alright, and so those are all your myotomes. So basically, the spinal nerve root, it's going to innervate and provide you like enough brain power to be able to like do these kind of motions, you know? So with mild tones, we're also going to have dermatones. So this gets a little So not only do we get motor innervation, but we get sensory innervation, and we have to test this in 3 different ways. We have to test it with superficial, light touch, so me like grazing my finger and being like, hey, do you feel this? And then I get like a little pin and like a nail basically, and I have to test sharp and dull in each region. So same thing with my eyes closed for the upper extremity. C2 is the posterior cranium, C3 anterior upper mid whatever cervical, C4 is going to be lateral superior shoulder, C5 lateral arm, C6 thumb, C7 dorsum of the middle finger, C8 the pinky, and T1 is going to be your medial elbow. Yeah. Let's go! Yeah, I feel pretty okay with that. And basically for each section that I named, again, we have to test all 3: superficial, sharp, and dull. We could talk about reflex. These are pictures, by the way. We could talk about reflexes, but we'll touch on it basically. So remember C5, C6 with the mild tone? It had like those different actions. Well, C5, C6 is going to power our biceps, and we know our biceps helps us with both supination and elbow flexion. So to test the reflex, you cops are familiar with reflexes, right? Like, you know, when you hit the person's knee a certain way, they kick out and it's like out of their control. Well, we have the same thing, but in the upper extremity. So we have your bicep tendon reflex, and we can test that as I lose my voice again. And what's going to happen here is that we're going to feel for the tendon. We're going to have them push into our hands so we get a little bit of resistance and feel that tendon pushing into our thumb as we palpate into like that armpit of the elbow. And basically we put our thumb over there and we use the mallet to strike over our thumb, and then the patient will involuntarily, if you did this correctly or if they have a reflex present, they will flex their elbow. Easy peasy lemon squeezy. We could do the same thing with the brachioradialis, which is very similar, except we hit at the end of the tendon towards like further down the arm. And then we could do our tricep, and we know our triceps are muscles that we have in the back of our arm, and the tricep tendon is going to be right here. We just hit it. Ta-da! Ashley, you got the right idea. Big bunk! And what's going to happen is that they should be eliciting some kind of extension, basically. Tricep, again, is going to be your elbow extension. Oh my goodness. So let's move to the lower extremities, okay? We do have leggies. So mild tones are going to be the same different thing, and I'm going to close my eyes and hope for the best because I really don't remember. Mild tones again are the muscles, so you have your L1, L2, and that's going to be hip flexion. L3, knee extension. L4, ankle dorsiflexion. L5, I want to say it's I want to say it's the opposite. I want to say it's plantar flexion. S1, I knew there was something between. Heck it all the heck. Alright, let me read it to you, okay? L1, L2 is hip flexion. L3 is knee extension, so you're kicking your leggy out. L4 is ankle dorsiflexion, so your toes to your nose. L5 is big toe extension, so there's something in between. S1 is plantar flexion, so you're walking on your tippy toes or pointing your toes down to the floor. And S2 is knee flexion. Oh no, I enjoyed Cells at Work. Now, did I get to watch the whole thing? No, but I watched the first episode and I'm like, yeah, I can appreciate this. And then I fell off the face of the earth. But yeah. Dermatones though, the sensation. So L2 is going to be the, middle anterior thigh. L3 is going to be medial knee. I wish I could show you because, oh goodness, just believe me when I say this. L4 is going to be lateral anterior mid tibia. L5 is going to be lateral malleolus, which is going to be your ankle, like the bony prominence off to the side. That's your ankle. S1 is going to be medial malleolus and the lateral foot. And then S1 is gonna be your heel. We've said cells at work anime night? No, I'm sorry. After my finals next week, I'm planning to do a Madoka marathon because Robo hasn't watched the Madoka series and hasn't watched Rebellion. And the new movie is coming out in about a month, so yeah. Huh? Once upon a time, life was better? My brain doesn't recall that. Let me see. Hi, Belgian Wolf. Hi. Once upon a time, life. I do vaguely remember this. I think I've seen the main character around the white long beard guy. I think I've seen like parodies or crossovers with the guy with cells at work, so that's actually really funny. Oh my goodness, first time chatter? Gallo_Wade. Oh my goodness, welcome! Oh my goodness, welcome to the couple chat. I welcome you with open arms. Open bear arms? Open bearcat arms. Welcome! We're just doing some anatomy studying and whatnot. I hope you're doing super well. Welcome to the couple chat. Welcome. Understandable. Time to catch up with the Madoka movies. Wait, you haven't watched Rebellion either? Oh, I mean, technically, I guess you can watch the Madoka movies, but I definitely have not watched the Madoka movies. Does that sound weird? I've only watched the anime and Rebellion, but I recall that the movies were basically the series summed up. I'll do more research. Whoa, Bearcat VTuber. Wow. Fellow Bearcat VTuber appreciator in chat. Let's go. Well, Gallo, nice to have you. Nice to meet you. Wow. Don't mind me. I have to, like, how do you call it? Speed run these notes. Don't mind me. So, like, the first two Made in the Abyss movies? Maybe? Basically? Question mark? I don't know. I'll definitely check it out after my thing. Again, like I said, at 7 I have this thing with my professor, and then tomorrow I have this thing with my professor, so there'll be time, I hope. And I'll cure reflexes. So we have the patellar, which is the knee jerk, and so this is the one where the person hits your knee kicks out. And we also have an Achilles. So for the Achilles, what's gonna happen is that they're gonna point their toes down or up. What reaction for Achilles reflex? Yeah, okay, I got spooked. It is what do you call it? Plantar surface, so they are gonna point their toes down. You forgot to watch the second season? Go watch it. We already watched it as anime night. Sorry, weeb. Go Manasawi. Anyway, let's talk about Babinski, okay? So Babinski is a different kind of test that tests for the upper motor neuron lesion. And Babinski's sign is very interesting. You just basically get like a dual end of something, or can even use your fingers, and you have to swipe in this motion. Normally when someone does this, their toes curl in because they're like, ah, that tickles. But an abnormal reaction would be that their toes splay out. So, da-da! Another way to test upper motor neuron lesion, which sounds a little bit weird, is that you can flick the middle finger of a patient, and you just like flick it a few times, and what's gonna happen is that it's positive if their index and middle fingers start to touch. And clonus is interesting. This is just basically movement that occurs on its own, and you can basically activate it, if that doesn't sound weird at all. And basically you just dorsiflex or bring their toes up to their nose in the slight flexion, and you do it really quick. And what's going to happen is that they start to become activated, and they go up, down, up, down, up, down. And with this up, down motion, it would show that clonus is apparent. Cranial nerves, I'm not too worried about. We can briefly touch upon it, and I think this is the bulk of it. So we have 12 cranial nerves. I regurgitate cranial nerves a billion times over, but let's briefly talk about how to test each one, and probably go a little bit more in depth, and probably wrap it up in probably about 10 minutes, okay? So the olfactory is our sense of smell. We have one nose, hence cranial nerve 1, and basically you just test the sense of smell, and what you would do is close one nostril and then test each nostril. Optic nerve, there's different ways to test it. You can check for their visual field, and basically it's just checking the peripherals and seeing, hey, are they able to see this? If I brought this thing like finger behind them and I slowly bring it closer to the center of their vision, when and where would they be able to identify it, and making sure they don't have any kind of like visual neglect. Cranial nerve 3 is ocular motor, so ocular eye motor movement, and this helps with eye movement. There's this test that you can do called the H test, which is going to test for each one. You can also check for convergence, so this is really interesting, where if an item is close up, like we will put like a pencil in front of you and be like, I want you to focus on this pencil, but I also want you to focus on like the exit sign on the far end of the door or far end of the room. Okay, focus on this pencil. Okay, now change your sight and now focus on the exit. And it's to test this convergence, and it's this idea of like your eyes dilating or constricting. Your eyes should constrict if an object is closer to you, and when the object's further away, it should dilate. I will still recovering from the suffering of the movie. Oh yeah, that movie very rough. You can check for pupillary reflex with light. So basically, oh my goodness gracious, great balls of fire. Sorry, the test I was explaining, by the way, is accommodation. Convergence is basically like this. I'm so sorry. I don't know what I was saying. I apologize. But anyway, reaction to light, basically, if someone shines a light into your eye will constrict, and if they don't shine a light in your eye would be either regular or a little bit more dilated, and it's just testing that in each eye. And all those are ocular motor. Trochlear is a part of the H test. It kind of all combines cranial nerve 3, 4, and 6. Ocular motor, trochlear, and abducens kind of combined together. Cranial nerve 5 is interesting because it is motor and sensory. So what you would do is that trigeminal means 3, and your face is divided into these 3 parts: ophthalmic, mandible, maxillary, mandible. One, I don't remember the name of the sections. I'm so sorry. My brain is eating out basically. But what you would do is you would test the sensation for all of these, but the motor portion is the jaw. So if your jaw can open and close, if you can clench your teeth or open your lips or do both at the same time, that's going to be testing the motor component of the trigeminal. So that's going to be that. I am not touching someone's eye with a cotton ball. Anyway, a facial nerve is the cranial nerve that gives us innervation to allow us to do all these wacky, fun expressions. And what's going to happen is that you just test to see if they're able to do it. And you can also test manual muscles. Not manual muscles, but you can do like a muscle testing where it's like, okay, close your eyes shut. Okay, I'm going to try to open them. And you can see that in this image right here. Vestibular cochlear, it's just your hearing. So you can like step away and then you could just tell your patient, but you have to be whispering. And you have to whisper 4 different phrases to them. So it has to be syllabic words. So they have to have 2. It can't be like dog. It has to be like corn dog. What is the other words they use? 14. Whisper. Bearcat. And basically you whisper these into their ear from the direction that this guy is in or the distance, and if they hear it, cool, great, their hearing's good on that ear. And then you repeat, you tell them to cover the other ear, and you do it again on the opposite side. There's a more specific way about testing it, and there's this thing called Weber's test where you use like a little tuning fork. That's something I will not get super into because I don't think I'll have enough time. Ryan's test is the same thing with the tuning fork, and it's basically testing to see how they can hear and how sounds are conducted in either air or bone, and how they hear better, and if they're having trouble with this, and blah 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 blah. It's fine. Glossopharyngeal is checking their gag reflex. I will not do that. Vagus nerve is basically you ask the person to say ah, and you use a tongue depressor, and you look at their uvula, and basically what happens is that you should note for symmetry, but for whatever reason it does move to one what do you call it, if it does move to one side, it's gonna move towards the healthy side. So it's moving away from the unhealthy side. So if you were to have like a vagus nerve issue on the left side, and then when you say, or when the patient goes then you could note that their uvula is going towards the right. No, there will be tuning fork tests. I just don't have time. I'm sorry. I have to meet up with a professor and look presentable in like 15 minutes, and it's gonna take me like more than that, you know? Alright, cranial nerve 11, the spinal accessory. So we know that our trapezius, or some of the neck muscles that we have, are innervated by it. So you can ask the person to shrug, and we'll try to break their form by pushing our weight onto them. And that's how we're gonna do like an indirect manual muscle test for that. And then our last cranial nerve is hypoglossal, so it's moving the tongue. And basically what you're going to do is note for symmetry. And if you notice it deviating, can my tongue deviate? Kind of. But if you notice some deviation like you see in the photo, what's going to happen is that this tongue is actually going to point to the paralyzed side, or the affected side. So anatomical position, knowing that this is this person's left and this is this person's right, we see the tongue is deviating to the right, noting that there's some kind of a lesion with the hypoglossal cranial nerve, and it's indicative on the right side. Alright, endocrine system is about hormones, and we could do thyroid gland palpations, and then this is a rubric. So we are done. We are free. We are done. Life is good. We don't even have to worry about it. I wonder where this person is. Oh, they saw my thing. Okay. Well, that's all. That's all I got, Cubs. Ta-da! 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 Thank you for joining me for regurgitation test information. I know it was a little impromptu just because I was just like, hey, I could speak about my notes. I really think it's cool stuff, but now I'm just afraid of like failing it, you know? Which is all very reasonable. But Cubs, please look forward to tomorrow. I'm a little bit nervous because part of me is like, maybe I should not do Yakuza, but I feel like I've stalled it twice already. I feel like we just need to get it finished at this point. So please forgive me. I think what I'm going to do personally tomorrow morning is just to wake up early before my work shift, and then from there I go to work, I come back, I study a little bit, and then maybe you could do some Yakuza together if that's okay with you Cubs, okay? Because I didn't realize this. I thought I was off Friday. I work Friday. I was like, no! I like checked it. I was like, no way! And so that's where I've been mentally since this afternoon. The grind never stops. The grind needs to stop. I need a break. Oh my goodness. Cubs, can you help me? Can you help me with a raid while I do this? A raid? Do we raid someone playing Fortnite? Magminogi, which I'm like shook, or a Baldur's Gate 3, and we'll put that poll for about 5 minutes. But yeah, Bearcat's job is never done. Hopefully it'll be done in 2 weeks. I'll take a little baby break. I'll take anything at this point. Holy heck. Murphy's Percussion is a funny name. It is, and it's a very funny test. Basically, you professionally hit someone's back and be like, does that replicate your symptoms? Anyway, because I have a poll going for potential people to raid. We have someone who's playing Fortnite, someone who's playing Magminogi, and someone who's playing Baldur's Gate. I do have to wrap it up, unfortunately, because I do have this thing at 7. So with that, I will politely shill, as I always do. So let's do this. So we have Discord, we have Twitter, and we have our socials. So Discord, tonight is anime night. Today is Wednesday, so we're going to be finishing Gundam G Witcher Mercury. Yeah. Super fun and exciting stuff. Yeah. We are going to also be... Oh no, I meant... Gosh darn it, I forgot to put another option in there. Someone's playing Banjo-Kazooie. And the poll. Alright, sorry. Banjo, Fortnite, Magminogi. Sorry, Cubs, you have to vote again, but now there's 3 minutes to the poll. Thanks for sharing. Thank you for joining. Thank you, Galo. Thank you, Caleb. Thank you. Sorry. Anyway, yeah, so the anime night's tonight at 8:30 p.m. EST. We are definitely going to be finishing whatever the heckie we can, okay? Okay. I still have to check if Zom is available. I will check that after my meeting and make the appropriate announcement. If not, tonight's anime night may be a little bit shorter, but if you haven't joined the Discord, heck, please feel free to join. I go make pings and I go live, and I promise I will stop the study grind one day, but today, definitely not the day. Meters next week. Next week is not any better. Everything is very unfortunate, but I really do want to thank you Cubs for your patience with my schooling and how like daunting it is. This semester apparently again is the worst semester, so like I think it will get better, thankfully. But yeah, thank you Robo for joining as well. See you at anime night. I will see you at anime night. Have a good one. Ashley says banjo like the instrument. Sorry, no, banjo kazooie. I should have typed it all up, but I got very lazy. I'm sorry. But yeah. What else is new and cool? Oh, Twitter. So tomorrow is my last day streaming for the week with Yakuza at 1 p.m. EST. I'm hoping it doesn't change. I hope that we could just get through the series and call it a day. But I'm dedicating between the time of 1 to 7 because again I have another thing at 7, so I'm like, oh gosh, I hope we can finish Yakuza. And if for whatever reason I feel like we're not getting close to it, we will definitely try to do our best and finish it the week after. But finals week might be a little bit difficult. Maybe we'll do like a combination study game stream, you know? Well, we'll see. But yeah, with that as well, please feel free to check out the socials. I uploaded a new clip. Thank you, Weeb, again for the clip of the penny challenge, where when I was done editing it, for whatever reason, it hit me that I had then explained the whole challenge wrong. And if I knew I explained the challenge wrong, I would have taken the time to edit it. But I thought it was a very fun, silly, quick edit. So it truly is what it is in this heck of a nerf. You know what I mean? I was just like, it's already too far. It's fine. I was so excited. I was just like, oh, I have this vague idea of how I want to change up my editing style. Let's do it like this. But you know, like, shortcut. It was a nice clip indeed. Thank you. I appreciate it. Thank you. But yeah, let's go get our raid message because I have only 9 minutes. So if you're not subscribed or don't have a tip lookout, absolutely no hecking worries. Feel free to use the berry emoji in the Galgal raid. You can also unlock the channel point, or you can also unlock a channel emo the Tipanya with channel points, so feel free to do that and participate. If not, feel free to grab the Tipanya with the Gaga raid. If you are subscribed, thank you for your support as a sugar bear. I appreciate you very much. And we're gonna be it looks like we're gonna be raiding into Momoka, who is playing Banjo Kazooie. Her model is super cute. Do not get me wrong, I am all for the Magmi Nogi person as well, so let me go ahead and shout these people out as well. This was the individual playing Magmi Nogi, if you want to go check them out. And this is the person that we're going to be raiding into. How do you call it? This person, I'm shouting them out just in case, because I feel like I forgot who was it last time. I think one of the Cubs got left behind during the raid, so I think it's very important to maybe potentially shout people out before we leave. So go ahead and copy and paste those raid messages, Galgal raid, and I will see you Cubs hopefully tomorrow. And if I don't get to see you tomorrow, then heck it all the heck, I'll get to see you sometime next week. Next week again is my finals week, so a lot of the stream is just gonna be hardcore studying. I did even ask for that whole entire week off from work, so I'm going to be studying 24/7, which smile emoji. We'll see how that goes. That's why we're having these review sessions with my professors at 7, so hopefully I'll get to format these notes during that time, and maybe we could do a little study together, or maybe it's just gonna be silent pomodoro most likely. So heck. Anyway, wishing you all Cubs the best. Please have a good rest of your day, your evening, and your night, and I'll see you later, okay? Lots of love. Bye.